Muy buenas tardes, colegas y amigos de ALAT. Es un gran gusto recibirlos en este simposio de Sociedades Hermanas, durante el cual tendremos la presentación del American Thoracic Society, la European Respiratory Society y, por supuesto, ALAT. Quiero presentarles a nuestro presidente, que no requiere mucha presentación, el doctor Mark Cohen, que también es presidente de PEERS, y les cedo la palabra para que nos presente a los profesores. Adelante, Mark.
Muchas gracias, Adrián, y gracias a todos por estar presentes en este tan importante simposio de Sociedades Hermanas. Tengo el gusto de presentar al profesor Liu Bos, que es graduado de la Facultad de Medicina de la Universidad de Ámsterdam y investigador de cuidado intensivo. Luego, él va a estar hablando de sus fenotipos del SIRA. Seguido estará la doctora Lynn Schnapp, que es presidenta del Departamento de Medicina de la Universidad de Wisconsin-Madison. Es miembro de la Facultad de la División de Alergia, Medicina Pulmonar y Cuidados Críticos de la misma universidad y graduada de Hedwig van Imberger y Leadership in Academic Medicine Program for Women. Actualmente es la presidenta del American Thoracic Society. A continuación tendremos a nuestro director del Departamento de Cuidados Intensivos, el doctor Manuel Vaz, que es internista, intensivista y fisiopatólogo y Departamento de Medicina Interna en Uruguay. Y completaremos con casos clínicos el doctor Francisco Arancibia, nuestro vicepresidente de ALAT y jefe del Servicio de Medicina Respiratoria del Instituto Nacional del Tórax de Santiago, Chile. Tendremos a dos de nuestros fellows de esa misma institución presentando un caso clínico, que es María Belén Fernández y Daniel Ramos. Así que podemos comenzar. Professor Boss, thank you for being with us. And please go ahead with your presentation. Thanks for being with us.
Thank you very much for the invitation. We're talking about subphenotypes of acute respiratory distress syndrome. I have no relevant disclosures for this presentation besides grants given to my institution that you see here. You all know the current definition of ARDS, bilateral opacities indicative of pulmonary edema within 1 week of a clinical insult. And you also know this useful image that has been part of the description of ARDS for a long period of time, where you see multiple pathophysiological processes that are involved in the development of ARDS. But the statement of this presentation that is that this figure is also misleading, and that there is no single patient that walks through all of these pathways towards lung injury, and that this is frequently forgotten in clinical trials. In this great paper by Lauren Ware, published last year in Intensive Care Medicine, she summarized the current approaches to randomized controlled trials in ARDS. On the top, you see the normal approach of no enrichment, so including all patients with ARDS in a study, an unselected patient population. And of course, this gives a large sample size, but also has challenges with the heterogeneity of the population that we'll be talking about today. And for most of the studies that have been performed so far, this has been shown to be ineffective in providing better outcomes for the intervention group. Prognostic enrichment is another approach, including only patients with a high risk of poor outcomes. This means that there is a higher likelihood of reaching the primary endpoint, and you need less patients in theory to get a positive effect. And indeed, there are some examples, for example, prone positioning in patients with severe hypoxemia, that seem to show that this effect can be effective in studies. What we will be talking about today, however, is predictive enrichment, selecting patients that have a high likelihood for response to the therapy, so an increased likelihood for therapeutic effect. I believe this is the future, and this is the topic of this talk. If you're looking at variation or heterogeneity in ARDS, we can look at etiology, biology, or physiology, and many of these have been described, and I will focus just on a few. I'll start with the systemic host response because Professor Calvi from San Francisco was the first to establish heterogeneity in ARDS in a prospective manner. This is the most famous study, already 7 years ago, published in Lancet Respiratory Medicine, where she used a data-driven analysis of variation of several blood biomarkers, but also clinical features of the patient, and showed that there were two phenotypes, so two subgroups of patients that had distinct characteristics. The analytical approach that she used is called latent class analysis. My slides are not moving forward anymore. And using latent class analysis, she was able to show that there is a hyperinflammatory phenotype and a hypoinflammatory phenotype, where the hyperinflammatory phenotype has high concentrations of IL-6, IL-8. The slides are working not very well. And the hypoinflammatory phenotype has a low protein C and bicarbonate. In another study with another approach, we were able, just using biological data, to find similar phenotypes with a hyper and hypoinflammatory response that led to prognostic enrichment, with a high mortality in the hyperinflammatory phenotype and a lower mortality in the hypoinflammatory phenotype. And the group of Professor Calvi went on to do post-hoc analysis of different randomized controlled trials and showed that there was a differential treatment response to a high or low PEEP strategy, fluid strategy, simvastatin, and recently in an observational study to steroids in COVID patients. So there is empirical evidence that there is a use for predictive enrichment. I'm going to move along to physiology, and especially to COVID physiology, where the definition of, or most patients with COVID on the intensive care unit, of course, are defined by the ARDS criteria, and the next presentation will probably discuss the differences between those patients and those with classic ARDS. In the beginning of the pandemic, there was a lot of discussion about L and H phenotypes. So there was already a sense that there were different groups of patients within this population of COVID patients. And the L was defined with a normal compliance. It was not recruitable with a lung full of gas. And H was low compliance and recruitable. But this was not driven by data and was mainly driven by the physiological evaluation of just a few patients that were identified at the beginning of the pandemic. We criticized that in this paper, where we said this is premature phenotyping that is not data-driven. We asked for caution using these phenotypes in the treatment of patients. This led to a lot of anger with some of the colleagues, and we received multiple letters challenging that we were that we thought that this was premature and that COVID was different from other types of ARDS and that there were different subtypes. So I want to present you with some data that we were able to publish recently in Lancet Respiratory Medicine, where we examined whether there was physiological heterogeneity within the COVID-19 population on the intensive care unit. Here we included intubated mechanically ventilated COVID-19 patients in a derivation cohort, a replication cohort, and another replication cohort, summing to about 1,500 patients. And we used three approaches. The first one, looking cross-sectionally at different time points between patients, but at time point 0, after 8 hours, after 16 hours, after 24 hours, using different variables. And you see the variables here in the bottom. This is actually a very similar approach to what Caroline Calvi had, identifying the biological subphenotypes. The result of this analysis was that there were no cross-sectional subphenotypes, respiratory subphenotypes of COVID-19 related ARDS. We then went on to use longitudinal latent class analysis. This is an approach that takes the data from multiple time points during the first 4 days of mechanical ventilation into account. And I will present you with the results shortly, that there were 2 subphenotypes identified here. We then used another approach that only includes the temporary variation of one single variable over time, group-based trajectory modeling that has gained attention for temperature trajectories in COVID and sepsis. So again, we used latent class analysis, a statistical method that can group patients that have a similar distribution in the data. So using this approach, we were able to identify one subphenotype that had high mechanical power, the power needed to move the air in the lungs, high minute ventilation, and a high ventilatory ratio. And over time, this difference grew. So on day 1, there was not a lot of difference, but by the time it was day 2, 3, and 4, the difference grew larger. Then we used the group-based trajectory modeling. So this was the approach that uses one of the variables to explore whether we could use just mechanical power or just ventilatory ratio to explain these differences. And here you will see respiratory compliance, PF, ventilatory ratio, and mechanical power. This is a type of mechanical compliance for the phenotypes in green and red, and the trajectories. So just using one variable in blue and gray. And you will see that for the mechanical power and the ventilatory ratio, both approaches, so the latent class analysis approach and the trajectory approach, gave very similar results. This is good because this allowed us to apply the same model in the validation cohorts, in the replication cohorts, and to evaluate whether these had consistent prognostic enrichment. This is indeed what we found, an upward ventilatory ratio trajectory. So what you saw on the previous slide, people who moved over time to higher ventilatory ratios, they had in all of the cohorts an independent association with 28-day mortality, but also with 90-day mortality, with the occurrence of venous thrombus events and with the length of mechanical ventilation. And there was no influence of treatment, and we looked at dexamethasone, anti-IL-6, and PEEP strategy on ventilatory ratio trajectories. We found similar results for the mechanical power trajectories, but those were largely driven by a high PEEP strategy. So it seemed that if the high PEEP strategy resulted in an increase in trajectory of mechanical power, this drove the relation with mortality. So to conclude this part of my presentation, there was no reason to assume, based on the data, that there are cross-sectional phenotypes of COVID-19 related ARDS. But when taking the dynamics of the respiratory physiology into account, 2 subgroups emerged with increasing ventilatory ratio and increasing mechanical power that were associated with a higher mortality. So this is an interim conclusion, is that ARDS is a heterogeneous syndrome, and there is physiological, radiological, and biological variation, and that we have largely disregarded dynamics. And I think this is an important factor that we should be taking into account in future studies. But as I told you, there is a need for subphenotype-aware RCTs. These are all analyses based on observational studies or on post-hoc analysis of RCTs that were already informed. And I will take the last few minutes of my presentation to talk about how such an SRT would look like. So there is actually one study that used a subphenotyping approach to randomize patients into a personalized care group or a standard care group. And this is based on lung morphology. So since the end of the 90s, beginning of the 2000s, two lung morphologies were identified. One is called focal, where the consolidations are primarily located in the dorsal and basal side of the lung. And the other is called non-focal, which is both diffuse or patchy infiltrates throughout the lungs. And these were shown to have differential responses to, for example, prone positioning, but also to recruitment, and have different biological origins, where the focal lung injury responds better to prone positioning, while the non-focal lung morphology responds better to recruitment and a high PEEP strategy. This led the life study investigators to randomize patients between a control group, so standard of care, with 6 milliliter per kilogram tidal volume, a standardized PEEP FIO2 curve, rescue recruitment maneuvers, and encourage prone positioning, actually the standard of care at the moment, against a personalized group where patients were identified as having either focal or non-focal lung morphology and received treatment based on that morphology, with the focal having a low PEEP strategy with mandatory prone position irrespective of the PF ratio, while the non-focal lung morphology had a higher PEEP strategy with mandatory recruitment and only rescue prone positioning. In the intention to treat analysis of this study, there was no difference between the group. But zooming into the per protocol analysis, in this case, the per protocol was that the patients were identified, were correctly identified as having the morphology that they should have. So the problem in this study is that the best way to identify the morphology as being focal or non-focal is a chest CT. But only 20% of the patients received the chest CT and the others received the chest X-ray. And that chest X-ray was misread in about 20% of the cases, which led to misclassifications. Accounting for those misclassifications, there was a significant reduction in mortality between the patients in the personalized group versus the control group. Zooming into this further, you can appreciate here that in the control group, so the patients that did not receive the personalized ventilation strategy, there was no difference between the misclassified and correctly classified patients, correctly classified as the solid line, the misclassified as the dashed line. While when they received the personalized treatment, there were large differences between the correctly classified and the misclassified patients. This suggests that when you use a personalized strategy, that it could improve outcomes, could improve mortality, but only if you do not misclassify patients, because giving patients with a non-focal lung morphology a recruitment maneuver is probably very, very harmful. Since this study, we have been working together with colleagues in Italy on developing a lung ultrasound method to identify focal and non-focal lung morphology. We were able to do that with very high accuracy when compared to CT scans. One should imagine that the accuracy of a chest X-ray is about 65 to 70%, while we gained an accuracy of about 95% using lung ultrasound. So this is I believe, the future of doing randomized controlled trials in ARDS. We are going to start with the Pegasus trial next year, which will be an international randomized controlled trial, mirroring the life study, but now using lung ultrasound guided mechanical ventilation versus standard of care. And we're recruiting centers from all over the world with experience using lung ultrasound. And if you're interested, you can always contact me. With that, I would like to end the presentation and hope to keep time for questions at the end. Not without thanking the team at my hospital. These are my PhD students in my unit, and the international collaborations that have contributed to the studies presented in this presentation. Thank you very much.
Okay,
Gracias,
thank you.
excelente charla. Les voy a presentar a la autora Schnapp, que va a estar hablando de ARDS en los tiempos de COVID-19 y si hay diferencia entre el clásico SIDA versus el asociado con COVID-19. Lynn, welcome, and please go ahead.
Thank you so much. I almost don't have to give my talk because a lot of it was discussed by Dr. Ba, so thank you. And delighted to be here. And again, gracias, obrigada. Thank you for the invitation. I also want to give a big shout out to the organizers of the meeting. I mean, we all know that transitioning from an in-person to a virtual conference actually takes a huge amount of work and effort, and kudos to everyone involved in the successful meeting. So thank you, and I have nothing to disclose. So I like to start off with a little bit of history on ARDS. You know, the first recognition really happened during World War I, the Great War. And World War I was the first major, it was the time when chemical warfare was first deployed en masse. And interestingly, the first gas was chlorine gas. And the problem with chlorine gas is it's actually too irritating and has a smell. So when you inhaled it, people would cough violently, would limit the exposure. So they then developed phosgene. And what phosgene does is it's not irritating, odorless, and it invoked an acute inflammatory process in the lung, usually 1 to 2 days after the exposure. The soldiers died of respiratory death in what we now recognize as ARDS, and it was originally referred to as shock lung. So 50 years later was the original description by Ashbaugh and Tom Petty and colleagues in The Lancet. And for any junior people coming up, just to take heart that this article was rejected by 3 different journals before it finally got accepted to Lancet. So keep on trying. And now it's one of the highly cited articles in ARDS. And what they described in 1967 in their 12 patients that got published in Lancet was patients presented with severe dyspnea, tachypnea, cyanosis refractory to oxygen therapy, loss of lung compliance, and diffuse alveolar infiltrates on chest X-ray. The etiology was varied from trauma, pancreatitis, viral pneumonia, drug ingestions, etc. The mortality in 1967 was about 60%. And it was the first application of PEEP for hypoxemia, as well as the indication that perhaps fluid overload contributed to worsening respiratory status. Well, if we jump forward almost another 50 years to the current definition of ARDS, the Berlin definition, it really isn't that much different from 1967. It is still based on clinical and radiographic criteria. Acute onset, less than 7 days, hypoxemia, P-DAF ratio of less than 300 on a PEEP of at least 5, bilateral opacities on imaging, and edema not fully explained by cardiac failure. And as I mentioned, 1967 survival was about 40%. Currently, it's anywhere from 60 to 75%. What made the changes in their survival? Whoops. I'm just going to point out a couple of the studies. Well, in particular, the study this is a seminal study demonstrating mortality benefit of a low tidal volume plateau pressure limited strategy. It's also the first time that ventilator-induced lung injury was shown to cause extrapulmonary organ failure. And I would say this paper really changed the standard of care for ARDS patients and was widely credited with improving outcomes of ARDS in the past decades. There have been several successful trials of supportive care, in particular, as I mentioned, lung reticular ventilation, prone positioning, and conservative fluid management. But as we alluded to, many of the biological strategies against ARDS has failed. So now I'm going to get to the question, is COVID-19 associated ARDS intrinsically different from ARDS unrelated to COVID-19? So as many of you, I'm sure, are very aware, early on in the pandemic with COVID, there was widespread anecdotal reports of increased hypercoagulable states in patients with COVID. Autopsies found microthrombi in the lungs. There was a strong correlation, as shown in this paper, of D-dimer levels with mortality. And people were describing hypoxemia out of proportion to compliance, suggesting that there is a vascular etiology. This led to the expansion of the use of intermediate dose DVT prophylaxis, some cases therapeutic anticoagulation, and even the use of thrombolytics for ARDS COVID patients. Now I'm pulling, this is a diagram from a paper from Lorraine Ware and her colleagues, almost actually now 10 years ago, reviewing the evidence showing microvascular dysfunction in ARDS. So there's been a long history of acknowledgement of coagulation and fibrinolytic pathway dysregulation. And what this figure also shows is the numerous trials that have targeted many of these pathways. This is just part of the chart from her paper, and it shows all of the different attempts at modulating coagulation and fibrinolysis in ARDS and in sepsis. And anticoagulation has failed to significantly improve the outcomes in sepsis or ARDS. And the point being that we know that there is vascular dysfunction in ARDS, and the descriptions in COVID align with what we know with ARDS. Furthermore, there were 3 large international clinical trial platforms who looked at anticoagulation in severe COVID, and they defined severe COVID as requiring ICU level organ support. The majority of these patients had ARDS, and the organ support was a ventilator. The primary outcome was organ support-free days. And they found that the therapeutic dose heparin did not improve clinical outcomes or mortality in critically ill patients with COVID. And indeed, there was a possibility of harm in these patients because there's a high probability of inferiority. Early on in the pandemic, there was also a lot of discussion about this hyperinflammatory syndrome with COVID and cytokine storm. And there were, again, case series describing the hyperinflammatory syndrome, the correlation with survivors and non-survivors. This is true, but I think if you go and look at non-COVID ARDS, we also have hyperinflammatory and hypoinflammatory phenotypes. And this is Caroline Calfee, who's getting, her and Lorraine are getting a lot of shout outs today, show that there is no difference in the prevalence of this hyperinflammatory phenotype in COVID-19 related ARDS compared to a non-COVID ARDS cohort. So there's clearly phenotypes within ARDS. It's not clear, there's not evidence that the COVID-related phenotypes are different or unique from ARDS-related phenotypes. I do want to highlight the study looking at dexamethasone in hospitalized patients with COVID. And this study was using 6 milligrams of dexamethasone a day for 10 days. And what they found was in patients who underwent mechanical ventilation, there was an improvement in mortality. This is actually a lower dose than some of the more recent studies in non-COVID related ARDS. And then the other interesting point is there was no difference, there was no improvement in mortality in patients who were not, did not have acute lung injury. And indeed, there was a suggestion perhaps of increased mortality. So suggesting that with steroids, like many other drugs, right dose, right time, right patient is critical. Now, we heard a little bit about differences or the evaluation of respiratory mechanics in COVID ARDS. And this is, I'm quoting the same article from Gattinoni, who described 16 patients with severe hypoxemia early on in the pandemic, despite relatively normal lung compliance. They were recommending low PEEP and avoiding proning in this population. Later described the two phenotypes, that type L, low elastance, VQ ratio, and recruitability, who were the majority of the patients, and this type H, high elastance, right to left shunts, and recruitability. And we're recommending that if patients fell into this type L phenotype, they should be ventilated using higher tidal volumes. But again, when you, in line with what we just heard, if you step back and now look at all the patients with COVID, you realize that they have similar respiratory system mechanics to patients with ARDS. And we've always known that ARDS has been a very heterogeneous syndrome. So is COVID-19 associated ARDS intrinsically different from ARDS unrelated to COVID-19? And I'm going to use this editorial. And really, for most patients, COVID-19 associated ARDS is, in the end, ARDS. But has COVID-19 changed our approach to the treatment of ARDS? And do we need to actually modify our definition of ARDS? And going back to our current definition, it is an acute onset of less than 7 days. And with COVID, we've realized many of our patients are presenting 7 to 14 days after symptom onset, but yet they really do have ARDS. And should we be relooking at this timeline for our definition? The current definition also is basically requiring patients to be ventilated, to have a P to F ratio of less than 300 on at least 5 centimeters of PEEP. And what about the unintubated patients requiring high levels of oxygen? Well, high flow nasal oxygen has been widely used in COVID-19 pneumonia, particularly in many resource limited settings. And there have been some studies looking at this, Michael Mathey and Lorraine Ware, and showed that patients who were treated with high flow nasal oxygen and otherwise met criteria for ARDS versus ventilated patients with ARDS demonstrated a similar 60-day mortality outcomes and had similar patterns of elevated plasma biomarkers of inflammation and injury, and suggesting that really it's the severity of the hypoxemia is the important criteria rather than the method itself that's used for oxygen delivery. And so I know there's actually several groups working on coming up with updated criteria for ARDS. So stay tuned. I think some of these issues will be addressed. And why is the definition important? Well, one, I think it's a recognition that patients who are treated with high flow nasal oxygen do indeed have acute lung injury and acute hypoxemic respiratory failure. It's important because we use these definitions to enroll patients in clinical trials, and we need to identify patients early in their disease to increase our likelihood of success. And it also gives us better epidemiologic data about the prevalence of ARDS particularly in resource-limited settings that may preferentially treat patients with high-flow nasal oxygen over ventilators. I think the other thing that COVID-19 has pushed forward is really the increased adoption of prone positioning for ARDS. Centers, many more centers have a lot more experience in prone positioning and are much more comfortable with that. I think that's a good thing. There's also been an interesting movement towards extrapolating the prone positioning for ARDS to awake prone positioning for COVID-19 patients. There was a recently reported meta-trial of 6 randomized control trials of awake prone patient positioning in patients with COVID-19 acute hypoxic respiratory failure. Their endpoint was a combined treatment failure of either intubation or death. And they found almost twice as much improved survival of patients who received awake prone positioning in blue compared to the standard care, suggesting that prone positioning may be appropriate for patients who are not mechanically ventilated. I will say the mean duration of awake prone positioning was 5 hours, and those patients who were able to be proned longer did better. Hard to know whether that was because they had less severe lung disease, but it is a very intriguing finding. I think COVID-19 has also really highlighted the need to be patient. We've certainly seen that our patients may require weeks, generally over 2 weeks, and sometimes months to that they need ventilatory support before they have a successful recovery. And I think the other important thing is we've shown the success of innovative trial designs during a pandemic. We can do this. The use of adaptive platform trials has been very successful in COVID, and it's enabled us to evaluate multiple therapies for a disease simultaneously against a single group. And as alluded to in the prior talk, I do think we need an enrichment strategy to understand the subphenotypes for ARDS. And then finally, I'll end with a quote from this perspective that in New England Journal. For the COVID-19 pandemic and other pressing medical challenges, the health of individual patients and the public at large will be best served by remaining true to our time-tested approach to clinical trial evidence and drug evaluation, rather than cutting corners and resorting to appealing yet risky quick fixes. And whether that's drug evaluation during COVID-19 and ARDS or evaluation of ventilatory strategies, et cetera, we need to stick to our tried and true method of clinical research and well-designed studies. So with that, I am going to make a plug for the ATS meeting. We are planning in person in San Francisco in May, and our late-breaking abstract deadline is January 26th. We just opened the portal for submission, so would love to see all of you in person in San Francisco. And with that, I will end, and I have a minute.
Thank you, Lynn. Excellent presentation. Very, very good. We'll be having the time for questions at the end. Manuel, I think you'll go forward. Francia, can we go ahead?
Perfecto. ¿Se escucha bien?
Sí.
Perfecto. Bueno, primero que nada, comentar que estoy muy agradecido por la posibilidad de participar en esta sesión y es para mí más que un honor compartir esta actividad con colegas de tanta relevancia como los que acaban de exponer. De manera que voy a pasar a mi presentación, que se basa en donde vamos a tratar de hacer referencia a lo que son las terapias adyuvantes en el síndrome de distrés respiratorio agudo. En primer lugar, definir qué son terapias adyuvantes en el distrés respiratorio agudo. Depende cómo los consideremos. Si es que nos referimos al término corriente que se usa para entender ese concepto, que son aquellas terapias que se le agregan al sostén respiratorio y no lo incluyen. Podríamos también usar una acepción más amplia, que sería aquellas terapias que procuran mejorar al paciente con síndrome de distrés respiratorio agudo y que incluyen al sostén respiratorio. ¿Y esto por qué? Porque el rol del sostén de la insuficiencia respiratoria, este tema que tanto nos apasiona, que incluye de la oxigenoterapia, la ventilación no invasiva, invasiva, el uso de maniobras como el decúbito-prono y el ECMO, tienen un impacto muy importante en la sobrevida de los pacientes y cuyo verdadero impacto muchas veces es difícil de evaluar en su magnitud, porque no se pueden hacer grupos controles sin ese tratamiento. Entonces, por ejemplo, en cuanto a este aspecto, en determinado grado de severidad de la insuficiencia respiratoria, todos los pacientes que no son tratados con estas técnicas de sostén de la insuficiencia respiratoria van a fallecer. Pero en cuanto a las terapias adyuvantes, no se han encontrado las terapias tales ni en el síndrome de distrés respiratorio agudo clásico, ni en el síndrome de distrés respiratorio agudo del COVID, en la cual sean tan impactantes los resultados, y lo que encontramos es que hay un grupo de pacientes no tratados, como en el caso de lo reportado en la recovery, que tampoco fallecen. Es decir, que hay un porcentaje significativo de pacientes que no reciben terapias adyuvantes, pero que no van a fallecer. Sin embargo, lo mismo no es aplicable al sostén respiratorio, por el impacto que tiene en la evolución de la enfermedad. Ahora nos vamos a referir al concepto de aquellas terapias que no incluyen al sostén respiratorio, es decir, terapias adyuvantes en el concepto clásico del término. Y también nos tenemos que diferenciar la aplicación de terapias adyuvantes en el distrés respiratorio agudo clásico versus el distrés respiratorio por COVID. Repasemos brevemente lo que son las bases biológicas, moleculares, celulares e inflamatorias del distrés respiratorio agudo clásico, que comparte algunas de esas vías metabólicas con el distrés respiratorio en pacientes con COVID, pero quizás en el caso de los mecanismos del distrés respiratorio por COVID, algunas vías son particularmente involucradas, algunas vías de la inflamación y algunas vías de activación del endotelio y de ocurrencia de fenómenos vasculares. Entonces, focalicemos en lo que es la patogenia de la inflamación pulmonar en pacientes con COVID y que impacta en la mortalidad. Por un lado está el rol de la citotoxicidad inducida por el virus, sobre vía aérea, alvéolos, vasculatura pulmonar, también en músculos respiratorios, a su vez en otros órganos. Asimismo, hay un rol para la respuesta inflamatoria en la insuficiencia respiratoria. Sin olvidar que también, como decíamos, existe un rol muy importante para el sostén respiratorio y también para lo que son las complicaciones que le ocurren al paciente críticamente enfermo en el curso evolutivo de su enfermedad, las cuales hay que reconocer y tratar oportunamente y precozmente para aumentar las posibilidades de que ese paciente tenga de sobrevivir. Con respecto a el rol de la respuesta inflamatoria en el síndrome de distrés respiratorio agudo en el paciente con COVID, tiene muchas implicancias. En primer lugar, las implicancias biológicas, de conocer los procesos biológicos que ocurren en esos pacientes, pero también diagnósticas, porque algunos biomarcadores pueden ofrecerse como métodos diagnósticos de la severidad de la enfermedad. y estar correlacionados con el pronóstico. Y a su vez constituirse mediante el bloqueo de esas vías de la inflamación en herramientas terapéuticas. Pero también el conocimiento del estado de respuesta inflamatoria del paciente en particular nos da seguridad en el manejo del paciente y en la comunicación con el paciente y sus familiares del estado de la enfermedad. También lo que nos permite es identificar aquellos marcadores que son de verdadero interés para la hora de diseñar, de destinar recursos para investigación de determinados aspectos de la biología de la enfermedad, así como en el diseño de políticas de salud y la enseñanza a nuestros estudiantes. Repasemos muy brevemente lo que es la evolución temporal de la enfermedad. Vamos a usar este caso clínico, es decir, un análisis en profundidad de un paciente en particular, tiene un interés muy, pero muy importante en nuestra práctica clínica, así como también los grandes ensayos clínicos. Pero en este caso es muy demostrativo de lo que es un análisis profundo de un paciente en particular, las enseñanzas que nos puede dejar. Este reporte de caso se refiere a un paciente joven, sano, deportista, que cursa una enfermedad leve, pero nos va a dar muchos datos para lo que es la extrapolación de esa situación a los escenarios del paciente crítico que es nuestra materia y nuestro ejercicio clínico habitual. Entonces este paciente que cursa en su domicilio la enfermedad, porque es leve, porque no le genera insuficiencia respiratoria, tiene inflamación del parénquima pulmonar analizado por tomografía, y a lo largo del tiempo, este día 30, día 60 y día 90 de la enfermedad, va mejorando hasta que el día 90 aparecen nuevas zonas parchadas. También la tomografía permite hacer un análisis vascular del proceso de la enfermedad. Y es así que en la etapa inicial, luego a los 30 días y luego a los 90 días, el paciente inicialmente va a tener un compromiso de la vasculatura pulmonar evaluada por una técnica asociada y un software asociado al equipo de tomografía. Y esto es importante porque el paciente tiene fenómenos vasculares de inicio, pero luego esos fenómenos vasculares ya no son tan importantes, el paciente recupera la afectación vascular. Eso nos permite tratar de extrapolar estos escenarios al resto, estos hallazgos en ese paciente particular, al resto de los pacientes, en particular los pacientes críticos que nosotros asistimos. Es así que entonces, en la etapa inicial de la enfermedad, hay un proceso de inflamación y luego al final de la enfermedad va a haber un proceso de reparación tisular del parénquima lesionado. Es así que el paciente se puede inflamar con distintas intensidades y si ese grado de inflamación es como nos mostraban los expositores anteriores, es una inflamación exagerada, el paciente se va a poner críticamente enfermo. Y también, cuando el paciente comienza a reparar sus lesiones tisulares, lo puede hacer de manera exagerada y dar lugar a las formas pulmonares del post o long COVID que nosotros también nos enfrentamos en nuestra etapa, en nuestra asistencia clínica. Y existe una superposición de esta inflamación y la reparación que también nos toca ver en el paciente crítico y que a veces nos obliga a destinar algunos tratamientos durante la estadía del paciente en CTI, porque agrega alguna reparación exagerada y formas de bronquiolitis y formas de fibrosis pulmonar y de compromiso pulmonar que se solapan con las etapas agudas de la evolución de la enfermedad. Es decir, que si nosotros conocemos mejor la respuesta inflamatoria y conocemos mejor y diagnosticamos mejor la etapa de reparación tisular, podríamos potencialmente modular esa respuesta inflamatoria o esa respuesta fibrótica con fármacos, por ejemplo, y para mejorar la situación clínica de los pacientes y su pronóstico. Esta etapa de reparación y fibrosis genera más incertidumbres que la anterior, que también las tiene. Ahora, ¿cómo se comportan los pacientes con COVID críticos? Y acá vamos a mostrar algunos resultados de algunos estudios que hemos llevado a cabo y cuyos resultados aún son preliminares. En este primer caso, nosotros utilizamos en los primeros pacientes que vimos para poder entenderlos un poco mejor, un análisis de los desenlaces clínicos cotidianos. En medicina intensiva, nosotros nos fijamos en la radiografía de tórax, nos fijamos en el intercambio gaseoso, y entonces estudiamos mediante un software del NIH que se desarrolló libre, que está disponible para todos los investigadores, que es el ImageJ, y mediante ese estudio nos permitía evaluar las radiografías de tórax en términos de área y en términos de densidades. Y asimismo analizamos el intercambio gaseoso y el cociente respiratorio como marcador subrogante de espacio muerto fisiológico. Y estudiamos en las 48 horas previas en estos pacientes que estaban muy graves e intubados y conectados a asistencia respiratoria mecánica invasiva, los factores clínicos y de laboratorio que pudieran predecir esos resultados, y también los de la mecánica respiratoria. Y lo que encontramos fue que la PIP se asociaba a, era el único factor que nos predecía el área, el cual es bastante lógico: mayor PIP, mayor área radiológica. Pero que a su vez, a mayor PIP, peor intercambio de oxígeno y peor hipercapnia, así como también peor espacio muerto fisiológico. Eso nos llevó a concluir, en la ausencia de biomarcadores predictores de la enfermedad, un rol para el espacio muerto y la hipótesis vascular, usar menos PIP y encarar clínicamente el deterioro de estos pacientes. Y diversos investigadores a lo largo del mundo encontraban hallazgos en el mismo sentido. Y focalizando en el endotelio, intentamos evaluar cuando los pacientes los clasificábamos en su primer contacto con la emergencia para un manejo ambulatorio, en moderados o en cuidados críticos. Y le medimos en ese día 1 los niveles de inmunidad y los niveles de biomarcadores endoteliales. Y lo que encontramos fue que el día 1 la actividad inmunológica nos permitía diferenciar los pacientes que iban a ir por el grado de insuficiencia respiratoria a cuidados críticos, o se manejaban en áreas de cuidados moderados, o se manejaban de manera ambulatoria. Y lo mismo nos permitía algunos biomarcadores endoteliales, como el caso de la calprotectina, el caso del CAM, el caso de GDF-15, GDF-15 o interleuquina 6, nos permitían diferenciar los pacientes críticos de los ambulatorios.
Muchísimas gracias. Perdón, Manuel, por el problema técnico, así que vamos a avanzar con los casos clínicos que estarán presentados por María Belén Fernández y luego seguido por Daniel Ramos, y tratemos de ser concisos para aprovechar el tiempo. Gracias, María Belén. Queremos que participe la gente joven de ALAT en esto y tendrá mucha discusión con los profesores invitados. Así que adelante, María.
Hola, muy buenas tardes. Mi nombre es María Belén Fernández, soy becada de Enfermedades Respiratorias del Instituto Nacional del Tórax y les voy a presentar nuestro caso clínico de distrés respiratorio catastrófico. Bueno, vamos a presentarle el caso de un paciente de sexo masculino de 28 años de edad con antecedentes de asma bronquial con escasa adherencia a controles y tratamiento, además antecedentes de obesidad con un IMC de 39 y un tabaquismo crónico suspendido con un IPA de 6. El paciente consulta por un cuadro de 5 días de evolución, de fiebre, tos seca, cefalea, odinofagia y disnea progresiva hasta hacerse de reposo, por lo que consulta en el servicio de urgencia el 11 de junio del año pasado. Al ingreso destaca el paciente febril, taquicárdico, taquipneico, desaturando hasta 54% con FIO2 ambiental. Al examen físico destaca crepitaciones vivasales asociado a uso de musculatura accesoria con una PCR COVID-19 positiva. Por lo que consulta, entonces, ese día al servicio de urgencia se maneja inicialmente con oxígeno de alto flujo, persistiendo la desaturación. Luego se conecta cánula nasal de alto flujo y pronovigil, pero persiste con PAFI menor a 100 y deterioro de la mecánica ventilatoria. Por lo que finalmente el mismo día recibe intubación orotraqueal en el servicio de urgencia. El estado clínico fue deteriorando progresivamente con una hipoxemia refractaria, sin respuesta a bloqueo neuromuscular ni prono, por lo que finalmente el día 14 es conectado a ECMO móvil y trasladado a nuestro centro. Ingresa a nuestra UCI con un Murray Score de 3.8, los cultivos de ingreso son negativos, igual que los antígenos urinarios, y destaca una PCR elevado con un dímero D de 18.000. Podemos ver acá la radiografía al ingreso, que es en el cuarto día de ventilación mecánica, que existen extensos infiltrados intersticiales en los 4 cuadrantes, y podemos ver en el escáner, ya al octavo día de ventilación mecánica, la evolución. Acá podemos observar cómo existe un importante y extenso compromiso parenquimatoso, que es más bien simétrico, con los bronquios permeables y los vasos a su vez también permeables. Acá son los cortes más representativos de este mismo escáner. Al octavo día de ventilación mecánica evoluciona el paciente con esta radiografía. Entonces ahora una pregunta a la audiencia. ¿Qué harían ustedes a continuación? No sé si a alguien le gustaría opinar al respecto. Ok. Seguimos entonces. Entonces, en ese día lo que se hizo fue que se dejaron bolos de metilprednisolona y se hizo una fibrobroncoscopía donde se observaron abundantes tapones mucosos, con cultivos que fueron negativos. El paciente requirió posteriormente fibrobroncoscopía cada 48 horas, seriadas por durante una semana, en donde ahí se observó la siguiente evolución radiológica. De los pulmones completamente velados que habíamos observado previamente, vemos cómo se fue abriendo progresivamente el parénquima pulmonar en las radiografías seriadas a medida que va avanzando la evolución del caso. Podemos ver cómo incluso del día 20 de ventilación mecánica, el pulmón del lado izquierdo está completamente velado y post fibrobroncoscopía al día siguiente ya tenemos una apertura del parénquima bastante más significativa. Posteriormente, el paciente evoluciona con un nuevo hit inflamatorio, donde se aíslan los cultivos una Klebsiella blé que se trata con meropenem. Y vemos cómo se condice con un deterioro radiológico seriado, y se realizó un escáner donde podemos observar que a diferencia del anterior, existe todavía un extenso compromiso parenquimatoso, pero ahora con un gradiente ventrodorsal bastante significativo, con mayor condensación con broncograma aéreo hacia las bases. Entonces es por esto que se decide, por este gradiente ventrodorsal, hacer un prono en ECMO, que podemos ver acá a nuestro paciente en prono, que se realizó durante 3 días, con posterior mejoría radiológica. Podemos ver cómo acá las radiografías fueron mejorando progresivamente después del prono. Finalmente, el día 15 de julio se hizo una traqueostomía y al día siguiente pudo retirarse el ECMO de forma exitosa. Acá podemos ver ya la radiografía posterior al evento más crítico, el paciente con traqueostomía, pero vemos ya una mejoría significativa del parénquima pulmonar con respecto a los controles anteriores. Finalmente se pudo remover la traqueostomía. El paciente presentó una polineuropatía del paciente crítico que fue revirtiendo. Al momento del traslado ya el paciente era capaz de deambular con asistencia, sin requerimientos de oxígeno suplementario, sin trastorno de deglución, y fue transferido al hospital de base el 7 de agosto del año pasado para completar su rehabilitación, donde una semana después fue dado de alta. Y acá podemos ver al paciente ya con su familia en su casa, que actualmente, bueno, ya ha retomado todas sus actividades laborales habituales y se encuentra en buenas condiciones generales. Muchas gracias.
Hola a todos los colegas de Latinoamérica, mi nombre es Daniel Ramos. Actualmente estoy realizando mi fellowship de enfermedades respiratorias en el Instituto Nacional del Tórax en Santiago, Chile, y a continuación les traigo el siguiente caso clínico. Este es un paciente de iniciales JDMP de 51 años de edad, sin antecedentes mórbidos, y que en marzo de este año, el 2021, comienza con un cuadro de astenia, tos y fiebre, y con un inicio paulatino de disnea. Consulta al servicio de urgencia, en el cual ingresa en malas condiciones, desde el punto de vista hemodinámico estable, sin embargo el punto ventilatorio polineico, con una frecuencia respiratoria de 32 por minuto, saturando 92% a FiO2 de 100% con mascarilla de recirculación. Por lo tanto, se conecta a cánula nasal de alto flujo con una FiO2 inicial de 60% y con un flujo de 60 litros. Y el 18 de marzo, que al poco llegar al servicio asistencial, se le toma una PCR de COVID que fue positiva. Sin embargo, el paciente presenta una mala evolución y se realiza una intubación orotraqueal el día 21 de marzo, y esto el paciente se deriva al Instituto Nacional del Tórax por el colapso de la unidad hospitalaria al cual había llegado. Esta es la radiografía inicial en nuestro centro asistencial al día 5 de ventilación mecánica, en el cual se observa un gran compromiso parenquimatoso. Se observa que ya está el paciente conectado al ventilador mecánico. En forma inicial se realiza una ventilación mecánica protectora en supino en primera instancia, con un volumen tidal de 6 ml por kilogramo, PIB de 7, con presión plató que nos daba en aquel entonces de 22 centímetros de agua. Posteriormente se evalúa la mecánica estática, y que determina un driving pressure de 15 y una compliance estática de 14. Y al ingreso presenta una PAFI, una razón de PAFI de 248 con FiO2 al 30% y un pH 736 con dióxido de carbono de 54. Intentamos realizarle un weaning rápido al paciente, pero tuvo una muy mala respuesta. Comenzó con fiebre, con aumento de los parámetros inflamatorios, y en forma inicial se realiza un aspirado traqueal, en el cual informa un Staphylo aureus meticilino sensible. Comienza en forma inicial vancomicina endovenosa, pero rápidamente desescalamos al conocer el germen cloxacilina. Esta es una imagen al día 16 de ventilación mecánica, que observamos un mayor compromiso parenquimatoso. Y este es un escáner concomitante en el mismo día 16 de ventilación mecánica, en el cual observamos un extenso compromiso parenquimatoso condensante. Acá podemos observar cómo la relación PAFI fue decayendo en el transcurso de los días, que ingresó con PAFI cercana a 250 y ya aproximadamente en su evolución cercano a las 2 semanas, 3 semanas ya llevaba cercano a 140, 130 de PAFI. En el día 24 de ventilación mecánica, el paciente aún en supino, con ventilación protectora, pero podemos observar que existe un aumento de las presiones de distensión del driving pressure, con una compliance estática mucho más baja en 12 y con una PAFI en 136. En este entonces, con esta radiografía, tenía una FiO2 de 50% con un pH 725 y un CO2 de 72. Por lo tanto, estamos viendo que no llegábamos a condiciones de ventilación protectora, y el paciente empezaba ya a aumentar CO2 y a empezar a hacer acidosis respiratoria. Realizamos un nuevo escáner en el día 24 y que observamos mayor compromiso condensante en el parénquima pulmonar. Y si observamos la comparación entre el día 16 y el día 24, se observa que existe un mayor compromiso parenquimatoso, principalmente condensante, asociado a un derrame pleural bilateral leve a moderado. Por lo tanto, le hago esta pregunta a la audiencia, que después la vamos a discutir. ¿Qué haríamos a continuación? ¿Qué harían ustedes? Lo que hicimos nosotros, comenzamos con terapia de secado en relación al paciente y a los signos de congestión y de derrame pleural, pero en forma paralela también hicimos lavado bronquialveolar, que nos dio un líquido oscuro, pero no purulento, macroscópicamente no se apreciaba purulento, y llevamos al paciente de posición supina a posición prono en relación al deterioro de oxigenación, y también hicimos un cultivo completo del paciente, aspirado traqueal, cultivos de catéteres, de sonda urinaria, etcétera, lo cual fue todo negativo, y se decidió dar un pulso de metilprednisolona. Fueron 500 miligramos por 3 días en forma consecutiva, por sospecha de neumonía en organización. Como podemos ver acá, graficamos la relación PAFI, que está denotada por la curva roja, y el gradiente alveolo arterial, que es la curva azul, y podemos observar que existe una mejoría paulatina de PAFI, y que esto acá lo graficamos también en relación a los puntos en donde se realizaron el prono. El prono, ya solamente con la modalidad de prono, mejoró el intercambio gaseoso, y posteriormente se grafica el inicio de los pulsos de metilprednisolona. Podemos observar que termina la metilprednisolona en la flecha roja. El paciente persistía con un buen intercambio gaseoso, con una respuesta favorable, y también acá les muestro cuando el paciente lo pasamos a supino. Pese a pasarlo a supino, el paciente siguió mejorando y sin un deterioro gasométrico, y por lo tanto se mantuvo en supino durante toda su hospitalización. Aquí podemos observar del día 28 ventilación mecánica al día 31, posterior al prono y posterior a los pulsos de metilprednisolona. Como podemos observar, en el día 28 el paciente todavía se encontraba en prono. Por lo tanto, el paciente, en relación a toda esta terapia, el paciente tuvo una evolución favorable, se realizó traqueostomía y fue llevado a una rehabilitación intensa multidisciplinaria. Y ya al día 40 podemos observar esta imagen de escáner, en donde se observa ya una regresión de estos focos condensantes, que quedan algunas imágenes aún, pero ya en una fase de resolución a nivel pulmonar. Acá tenemos una comparación entre el día 24 de ventilación mecánica y el día 40, y esto mediando la terapia de prono y los pulsos de metilprednisolona. De acá ya encontramos ya al paciente en su alta hospitalaria y con todo el equipo del Instituto Nacional del Tórax, muy alegres por haber llevado al paciente, que haya salido en una buena condición y que se haya ido a su hogar. Muchas gracias por la atención, espero que haya sido de agrado el caso.
Excelente, gracias María Belén y gracias Daniel. Creo que todos hemos tenido casos similares y que hemos aprendido muchísimo de cada uno de los casos. Tenemos la sección de preguntas. Thank you, everyone. I think we have learned a lot. COVID, I know, has been a headache for all of us, but I think it has opened up our eyes to good things, learning things, and definitely having an order or how we can do further RCTs in ARDS patients, either COVID or no COVID associated ARDS. Professor Boss, one of the questions in the audience is definitely the movement of patients out of the ICU, having the ultrasound guided severity, and trying to do the imaging type of phenotyping. Yeah, I know that you're going to be starting the recruiting of these patients, but do you think it's now that the COVID numbers are going down, are we going to be able to have information pretty quickly, or when do you think we'll have some information from that type of study?
So this is not a study in COVID patients alone, it's in all causes of ARDS, and COVID, of course, typically presents with a more diffuse type of lung injury. So I think that would not be the ideal population for such a study, to only include COVID patients. So it's all comers with ARDS in the intensive care unit with a PF below 200 at 5 pp.
And talking about that PF lower than 200, Lynn, you saw that most of your patients with a awake proning position had PFs not in the 150s or the 100s, and they did pretty good. Do you think we need to do some adjustments on the PF ratio to see how aggressive we need to be with the proning, or doing it earlier and longer time, not the 16 hours, but it's going to be hard to have those patients awake and having them in the prone position, like you said, but on those that are ventilated, they have a higher PF ratio. Do you think we should start proning a lot earlier with a higher PF ratio?
Yeah, I mean, it's a great question. We are in a bit of a data-free zone for that. The best study looking at proning in the ARDS restricted it to those with P to F less than 150. we don't know whether patients with PF greater than 150 would have a similar benefit. But that being said, I have prone patients who didn't quite meet the criteria of the PROSEVA trial with success. I've used it more on the patients who have a higher BMI, and I'm concerned that there's some abdominal compression that's impinging on the respiratory mechanics. But that is, again, data-free zone.
We're learning, definitely. Yeah. And Manuel, I know you had problems with technological problems there, but definitely the adjunctive therapies that we're having, once again, as we discussed with the phenotyping of our ARDS, which would be the types of adjuvant therapies that you would try to add to our respiratory support that we have right now. The steroids, are they going to help for the non-ARDS patients or not? What would you conclude? Manuel, can you hear us? No? So I would discuss, what would you think, Lynn and Louis, about the two cases that our fellows presented today? What do you see that could have been done differently, or would you have done it exactly the way that they did it?
Well, I wasn't, I tried to follow along. My Spanish is not that good, but it seemed the first case was talking about how repeated bronchoscopy helped the lung collapse in a patient with ECMO. It's a little challenging. We have done bronchoscopy in that setting, but we haven't done it on a routine basis on a set schedule of every 48 hours. That is the part I have less excitement over. If you look at the studies, not in the ECMO setting where the lung, the tidal volumes are so much smaller, but if you look in the non-ECMO setting, the data shows that yes, bronchoscopy can help with collapsed lung, but it's no more effective than good chest PT. And then if you don't obviate the underlying cause of lung collapse, they're just going to collapse again, whether you bronch them or not. So I might have just done a first bronch, make sure I'm not missing anything, and then followed and seen how they do.
Aggressive chest PT. Okay.
Yeah.
Mm-hmm. And Louis, on that second case.
And the second case was a bit more difficult to follow for me with the slides in Spanish too. The first one was a bit easier. But I with regard to the repeat bronchoscopies, I would like to comment that I think I would not use it as a therapeutic in these kind of patients. I think that's the challenge, I think, with bronchoscopy is that you feel that you're doing something and therefore it feels good to do it. But actually it has potential harms in these patients too, especially when they're on anticoagulation. And I've had a bleeding patient with due to a bronchoscopy with ECMO, and that's a very bad complication in that setting. It can be deadly, of course. But I think what we are doing too little and we should pay more attention to is to really look for complications in these patients of prolonged mechanical ventilation. So the aspergillus and I think also the herpes virus reactivations in the setting of ECMO are quite important. And what I like about the case a lot is that it shows that you need to be perseverant in these patients and do not give up. And I think this is, at least in our setting, a challenge, because once you commit to the ECMO, there is a continuous discussion whether it is useful to continue further and further and further. And I think the data starts to show that once you commit to it, you should stick with it. to the end, until either the patient completely gives up, or it's a point where the ECMO cannot be run anymore because of lack of vascular access, for example. So I think that was for me a great take-home message from that presentation.
Thank you very much.
Hello, I would like to respond a little bit why we think that the repeated bronchoscopy in these patients is very important in ECMO patients, different from other scenarios only in mechanical ventilation patients, because, well, catastrophic distress that require ECMO, the main purpose of ECMO is to leave the lung in like a resting lung. So normally we use like very low tidal volumes, normally less than 4 millimeters per ideal weight, and very low respiratory frequencies, around 8 or 10. So normally in these patients, the bronchial cleaning is very diminished compared to normal ventilated patients. So it's very common to see lots of mucal plugs in these patients that aren't very easy to eliminate normally as other normal ventilated patients do. That's why we think that serial bronchoscopy in these patients have very good results compared to patients who aren't in ECMO and aren't in lung resting lung.
Yeah.
I don't know if you think differently from this.
Can I ask a question, Maria? Are these patients fully sedated and paralyzed, or are they awake?
No, they have to be fully sedated and normally with paralyzed also, because to make this a state of lung rest, like having 8 or 10 breathings per minute, and such a low tidal volume, we need like total sedation and blocking.
Yeah, I think that is very different from our setting. I think we would never, these patients, we would keep them awake, give them a tracheostomy quite quickly, and just let them breathe without much support. So basically trying to mobilize and wean them from the ventilator even during ECMO. That is the approach that we've been taking. So I think that's why we don't encounter the mucus plugging that you would encounter in these patients. And that's something of an alternative method, I think, to handle this. So I understand if you've completely paralyzed the patient, then this is one of the problems that you will encounter. Yeah.
Yeah. And we also try to not sedate and not paralyze our patients on ECMO. As a matter of fact, we are trying to be very aggressive about getting them up and mobile and participating in physical therapy as soon as possible on ECMO.
Very good. I really thank everyone. It was super, super enlightening. We all learned a lot. Thank you, Louis. I know it's late in Europe. Thank you, Lynn. It isn't too late in the US for you. And thank you, Maria and Daniel and Manuel. Thank you. Have a good time.